Here we are. Welcome to London, guys. Welcome to London.
So, the first question is really easy to answer. If you have a look to the first page of the Bible of CLTI, and it is coming from Roberto Foresi. It's a really classical one, and it basically mentions that, as you can see, BTA disease has the strongest association with CLTI, because with just one vessel disease, you can end up having an ulcer, a wound. So let me start asking you, what is your typical strategy when you are just planning a case of CLTI? Red flag, you are following the angiosome concept. None? Good to know. Green one, woundosome concept. Okay, good. Number C, let's say you are Mike. You follow the Mike-some concept, your own style, freestyle. Okay, and since we just have 3 flags, the fancy movement for the last one is, show me you, show me. Ma, ma, ma. Okay, so are you the ones who do the best and got notes? No, okay. So as you have seen over these hours, the angiosome concept is a little bit outdated, because basically this was designed, you know that, by plastic surgeons. And you may probably wonder, in our patients, the majority of them, diabetes, chronic kidney disease, and all of these connections on the foot are usually lost, either because you have this chronic kidney disease, you lose the shock vessels, or because you have, these guys had already had an amputation. And also, we also, you know, you're aware of that, we have a lot of anatomical variations at the level of the foot, and this probably doesn't follow well the angiosome concept. And finally, large wounds usually involve different angiosomes. So what we are talking about nowadays is the woundsome concept. So trying to get foot straight to the wound. And this is because we have seen that if you achieve a wound blast at the level of the wound, you decrease the wound healing rate, the time, you increase the wound healing rates, and also you decrease the amputation rates. And as you can see, this is already?
Yeah, and it's published by, they're publishing it.
It's on the way. There is a consensus document just run by Lorenzo. It's about to be published in the Journal of Endovascular Therapy. More than 100 key opinion leaders around the world talking about the woundsome concept. So I strongly recommend it to them.
It's the first time that 100 people agree on something in medicine, probably.
Okay. So you are already aware about what is the woundsome revascularization? Are you? Are you one? Show me the money, right? Show me the money. Okay, let me show you how do we do this sort of stuff. So let's say this guy with a heel ulcer, no pulses below the knee. And as you can see on the angios, has an occlusion of the SFA and also disease anterior tibial. So what we did initially, just to recanalize as usual the SFA, and also we fixed the anterior tibial with this nice outcome. Even the plantar arch was basically feeding, but the wound at the level of the heel remained the same. So it was not really an amazing outcome. So that's why we decided just to aim for the posterior tibial, for the plantar system. And as you can see, we were able to cross with our Command ES as a workhorse, but perforation. Who cares? Just go for the dorsal system into the plantar arch, perforation. So, perforation, what would you do? Red flag, would you use a loop wire to overcome the perforation? How many of you? Let me see your flags. How many of you? One. The body wire maneuver. Do you know what is the body wire maneuver?
You call a body?
Luis.
You call a body who comes with his own wire?
Luis, what is the body wire maneuver?
It's when you try to overcome not going to the same where you already have a wire.
Okay, you leave the one wire in place in the hole, so this avoids the second wire just to end up in the same hole. This is for the fellows. Or you are aiming for the Buzz Lightyear maneuver.
Towards
Yellow.
infinity and beyond.
Yeah, to the 4 foot and beyond.
I didn't know that.
Or how many of you give up?
August.
Buzz Lightyear. Oh, yep.
Sir, I have a comment question
Yep.
for you. I think context is everything, isn't it? We don't really know how old your patient was and say what the comorbidities were. Because I think that, say, in the unit I work in, if the patient's younger and fitter, we would probably do a sort of more detailed duplex anatomical examination of the foot, because very often you can find the medial lateral plantar artery.
Okay, good point. And let me take advantage of having also the king of the distal bypass. We have Gonzalo, and I know here we always talk about this desert foot in a standard angio, super selective, but now these guys are running a new way just to try to underline these sort of hibernated vessels. So can you just give us some insights?
Thank you, August. Yeah. In our center, we are trying to conduct a trial at this moment where we are comparing our standard imaging protocol for preoperative target choice in ultradistal and below the ankle, where we do our angios from the groin and not super selective, as almost everybody in this room probably does. What we find is that the route the blood takes to get to the very small vessels on the foot is not exactly what we expect, and many times the blood comes from collaterals of the profunda. So you really have to inject on the groin and just wait as long as it takes before you have all the foot filled with blood. And of course, when we do these techniques, we see targets that most people do not find. And of course, because we are very dedicated to open, normally, if we have a vein, we can go there and we can do a bypass, which in this case, if you get the correct pressure, even if it's not on the artery that goes to the heel, you will probably manage the closure of this wound, because the pressure you get with the open vascularization is really greater than you get with endo. But that's just the concept that we are exploring now.
Yeah, but wait a second. And what's your protocol? Because I'm very interested. Do you inject 20 milliliters of contrast at least?
A little bit more.
Exactly, at least,
we
yes.
inject 60 to 80, depending on the patients. It's less than angio-CT if you think about it, but you really need that bolus, and then you just track the bolus. The speed when it comes down, it's very dependent on the patient, but it's the way in our practice that we find the most vessels. So many cases when we say there is a desert foot, really it is not the case. We see per year, and we do a lot of these cases, maybe 1 or 2 cases where we really say, we can say that there are no vessels on the foot. Because normally, if there is a foot, there must be a vessel there, or else there wouldn't be a foot. So it's just, we think it's a matter of better planning and better pre-op imaging to get the whole picture.
Okay, great. So you know we are pretty Buzz Lightyear guys. So we decided to puncture the plantar arch. So we punctured the plantar arch, which has a nice size, and then went through the lateral plantar into the posterior tibial, rendezvous, balloon dilation, and then, as you can see, we achieve a complete revascularization of the entire foot.
Wait a second. Because, I mean, many people would say, but why did you puncture the plantar arch? Then you can get into trouble, because if you damage the plantar arch, the patient is going to go to acute limb ischemia. Am I right? This could be something that some people could say. How do you feel about that? How do you feel about the fact that if you don't do that, if you don't do something, the patient will get amputated anyway?
Sorry, Lucas, where did you puncture the plantar arch?
Where?
Yeah, where was the location? Because there was some sort of dorsal part of the foot arch already.
There,
Yeah.
in the middle, in between the third and the second toe.
And you can see it was not a straight puncture, because there was a little bit of contrast, so essentially how much you insist. But this patient is going to be amputated anyway. So, I mean, I think it's good to have a very honest conversation with the patient, saying, listen, with this thing, because it's a second attempt, you can lose the leg straight away in 2 days. but if we don't do it, you will lose the leg in 2 months. Do you agree with that? Or?
Yeah, I think in answer to your question is, I think this is a CLTI. If you don't do it, if the patient's going to lose the leg, then you need to do this. And I think chances of developing acute limb ischemia from that is low. It's not high. I think you're dealing with very diseased arteries in the first place. My question to August is, what did you use? Is it ultrasound or fluoroscopy guided? Or
Fluoroscopy. And mainly...
But when you do the angiogram, there's very little flow there. So and also...
Mainly, in that sort of cases, you can see this is our classification of retrograde punctures of the BTA vessels, and hopefully this is going to be published soon in the Journal of Endovascular Therapy. And when we are talking about zone 3, a good thing to have is some calcification. So usually calcification on the arterial wall, it's the enemy, but in these sort of cases, since you cannot do it on ultrasound, and if you want to perform a roadmap, it's really difficult just to keep the guy really still, or you just need to move the foot. So calcification, arterial wall calcification, it's really of help.
Let's go with the second case.
Okay, so clinical outcomes of these guys, as you can see, wound some concept, we reach the wound with the flow. 3 months later, complete wound healing, TCPO2, 56 millimeters of mercury. This is the concept, the overall concept. So the second case is pretty interesting. This is an acute diabetic foot. This is a guy with no pulses below the foot. Wi-Fi is 233, which means that toe pressure was below 0.3. So as you can see, we have tight stenosis at the level of the anterior tibial, and also distally, as we have said, nothing really amazing, I would say. So what would you plan for these guys? We try just to cross our anterior tibial, and then we navigate with a wire, and then we change to a serial wire. But look at the funny movement of this wire. We perforate again. We sometimes don't perforate, believe me. So what to do? No vessels to be punctured retrogradely, no clear vessels, another perforation. So would you reproduce the wiring maneuvers? Red flag? Let me see your flags. Red? No. Someone thinking about DVA?
The posterior tibial artery origin was above in the popliteal, which could be a good thing. There could be a good flow.
Yeah.
There's also a little bit of anterior tibial to leave some space for the ischemia which comes. So I don't think it's a bad candidate for PDVA. What do you think?
Probably think so, but I think you must address the question to the lymph lower guys. So we have Hani and Daniel not paying any attention. So why do you consider these guys a good candidate for PDVA?
Say yes.
Yes.
Very good. Okay. Okay.
Honey,
And then
why? So the angio. And would you perform the PDVA as a first attempt, as a primary?
No. So at least one
So you perforate once and then the
Yes, exactly.
Okay.
If I perforate, I wouldn't proceed.
This is also a rule. Okay.
sorry, and another thing that I want to mention. If you perforate in this vessel, do we care? Is it like bad? Are you scared? No, the answer is a big no. You are going through an occlusion, despite you have a little bit of contrast outside. It could be like a bit less in order to get a better picture later. But like, there's no problem in perforating for a CTO apart from the fact that you can't recanalize it. There's no damage. So to go for an occluded artery, if you want to try to go for the posterior tibial, there's no damage you can create. I mean, probably little collaterals, yes, but if you have to balance, an occluded vessel has very little flow. So if you perforate, if you destroy it, if you then go to a landing zone which is healthy, it's a different thing. So
okay.
If you go for an occlusion.
So how many of you would give up? No.
Come on.
So we have plenty of, give up. Plenty of bus Lightyear guys, which is basically what we did. So thanks God we had a reconstitution in a digital artery, and we decided to puncture it retrogradely. So we punctured following the calcification, as you mentioned, and we were lucky enough just to get in, and then an ultra-low profile balloon. This is the Armada XT balloon.
Wait.
Because you're puncturing digital arteries, I would like to ask if Gonçalo thinks that this would be a bad movement to puncture, because that could be a a possible target for a bypass or not? That digital artery, is it a target?
Yeah, a good question. Let me ask Gonzalo.
Not the digital arteries. So
And if he says no, it's no.
If you puncture zone 3, I think it's perfectly safe. The problem is what you do with zone 2 and zone 1. Because if you have a relatively healthy artery and you start ballooning there, then maybe we are losing targets for other arts. So it's something that you have to
So you buy
bear in mind
zone
when
1
you
and
do it.
zone 2. You don't want to listen anything about zone 2 for
I do want.
poor toes. Okay, so as you see, we basically puncture with a 21 gauge needle, 22 gauge needle, and then this is our command 18 wire. As you can see, no, this is a 014 wire, so it's a command ES, and then we open the gate of the anti-gate wire with a balloon, what the so-called CAD technique. You are aware of that? Anyone here is no idea about the CAD? And as you can see, we were able to cross anti-gate with our wire, and then we place it into the digital artery to perform some hemostasis of the puncturing, and then balloon dilation of the DP, the anterior tibial, and of course, the tight stenosis at the proximal aspect. And look, the amazing flow in the anterior tibial, the DP, and the most important thing, the arch at the level of the wound, again following the wound concept. And the clinical outcome of this guy, forgive me about the amputation again. So granulation tissue, and then 2 months later, complete wound healing, TCPO2, 58 millimeters of mercury. So this is the case. This is the third one, lady without pulses below the knee, and as you can see, 4-foot necrosis. We performed the angio, and again, we didn't see anything really amazing, a tiny tarsal artery there. Regardless, this tiny artery, we thought, why not to do something? So what would you aim for? Anterior tibial, red. 1, oh, it's 6. Posterior tibial, none. PDBA, none. So the rest, I guess, pray and cry. Okay.
Actually, it's legal.
Okay, so we anyway tried to cross through the DP, but we failed. No perforations, thank God. And then we tried just to find a place through the tarsal, and again, we didn't get anywhere. So we decided just to recanalize the posterior tibial in a subintimal. We re-enter in the lateral plantar. As you can see, we were able to navigate nice and easy, probably an hibernated arch from the back door. It's really usual to see that coming from the back door is a lot easier than coming from above. And look, this desert foot is the same picture, the same lady, with this amazing flow at the level of the ankle and also at the level of the forefoot. We performed a TMA, 7 days later, everything was already closed. This is one of my favorite ones for the fellows. So we have this patient, 4-2 necrosis, DP pulse, and then what do you do with diabetic guys with distal pulses? Red flag, you got the call. This fucking thing is not mine. Distal pulses. So it's a typical thing my fellows, when they get a referral, say like, first question they say is like, do they have pulse? And if they don't, they say, oh, fuck. But if they have, they just go. So, red. You don't care about these guys with distal pulses. Okay. An honest guy. Green. Come on, you're a vascular surgeon. Chop, chop, chop. Green? No? Okay, how many of you think that these guys deserve a further assessment?
I mean, of course.
Oh, no.
Guys, it's impossible someone with pedal pulses has this kind of foot anyway. Usually it's this ulcer, like it's a pressure ulcer or something, but this guy shouldn't have pedal pulses.
Let's be completely honest.
Yeah? Something more.
How many of you at your place, in your department, with distal pulses and a black toe, will basically request an angio and try to justify the angio to your IR?
A duplex is a duplex, but maybe PAT, maybe below the ankle duplex, because that's the thing. You know, you can have great pulses and, you know, absence of fetal arch. So show the case also because we're running out of time.
Okay.
I'm sure it will be like this because
So the thing is,
They've still got a toe there, so you could do a helix toe pressure as well. And that would sort of give you a bit more impetus to do the angio if it's low.
Okay. We, unfortunately, basically chop. But as you can see, this was not healing at all, and we requested an angio. And the answer why it didn't heal is that because it has a complete arch occlusion, which we treated with a 2 millimeters balloon, and following the plantar arch revascularization, the wound healed completely in 7 days. So this is again the concept of the angiosome. Another case of a guy with a third toe.
I think we run out of time. I mean, it's amazing.
Okay.
But like I think if we know we're gonna end super late and we're gonna not have a party. Can you go to the conclusions? I love it. You know how much, but we need
that's
to cut
fine. That's fine. So let's skip this one. Shall we see this quickly, super quickly? Okay, the importance of the multi-wire approach, this guy with a peroneal artery, reconstitution in the medial plantar, and then we try to cross anteriorly, we fail, we're not able to just to re-enter in the lateral plantar, but we were lucky enough just to place the wire in the medial plantar, and from the medial into the first metatarsal, as Andrew has shown, get back into the arch, and then into the DP. As you can see in the AP view. But we were not able, because we didn't have any support, just to recanalize retrogradely. So what we did is just to puncture retrogradely following the landmark of the wire, and the wire just nicely went through. And as you can see, the anterior wire, again, out of the vessel. But surprise, surprise, the balloon was unable just to progress. So what to do in this case? What we did is just to inflate a balloon, and then antegrade, we puncture the balloon. We have published this. This is a balloon-assisted antegrade puncture. And then we lodge a wire inside the balloon and retrieve the balloon and the wire simultaneously, and you end up having an antegrade recanalization. And through this antegrade support catheter, we were able to perform the plantar arch recanalization and also the lateral plantar, as you can see. And then following balloon, balloon, balloon. I'm trying to speed up. So this is the rendezvous at the level of the catheter, balloon dilation of the lateral plantar, the arch, the DP, and also, of course, the medial plantar and the posterior tibial. And this is the final outcome.
4 millimeter at the level of the TP trunk, just to go back to the size of the vessel.
At least.
At least, even 10 sometimes.
Okay, so this is the final outcome. So take-home messages. Complex BTA recanalization is feasible and safe and should be considered in specific clinical scenarios. You definitely need to be familiar with the anatomy. You need to know the connections of the dorsal and the plantar system, use dedicated devices, and master the bailout techniques, because when it looks fancy and sexy can become a complete disaster in case of failure. So are you convinced, my friends?
Absolutely. Thanks a lot.
Thank you.
Thanks a lot, August. And amazing presentation. You know, for me, I would stay all day, all night, sitting here looking at these cases. Sometimes they also pass the wire. It doesn't always perforate, and the same with Marta. Sometimes they succeed. Anyway.